This is a clinical case presentation on our patient Patrick. Factors that could be contributing to Patrick's respiratory symptoms could be the fact that he has been a smoker for 40 years and he is suffering from COPD. So 90% of smokers or long-term smokers who have now quit are living with COPD today. He was a smoker for 40 plus years, so in the defense of the cigarette smoke, it can cause escalation of the inflammatory process in the central and peripheral airways. Initially beneficial, macrophages and neutrophils are produced in defense of the cigarette smoke. COPD can cause constant infection and extreme mucus production in the lungs, which make it difficult to breathe. This could be what Patrick is suffering from with his shortness of breath. The test results also show that his hemoglobin is a little bit low, above just under the average of 130. This anemia can be caused from low hemoglobin, which can also cause shortness of breath in extreme circumstances, which could be the case for Patrick. Also, the fact that he is overweight, his waist measurement is 104 centimeters and the normal for a male is 94 centimeters. His height is 180 and his weight is 95 kilograms. This makes his BMI 29.3, which sits him in the overweight category. This can contribute to him being lethargic and it can actually cause him to be out of breath as well. He's carrying that extra weight. So they might be a few of the reasons why he is suffering from his shortness of breath. The factors I have interpreted that may be contributing to Patrick's heart rate is the fact that he is suffering from COPD, so the constant mucus production and the constant struggle to cough up and being out of breath can cause the heart rate to increase out of panic, and just because he is constantly coughing and not breathing regularly. Having high sodium levels could also contribute to an increased heart rate. Patrick's is 155 beats per minute and the normal range is between 60 and 100 for adults, so it is quite high. So yeah, having higher sodium level, he is just out of the normal ranges. He's 150 millimoles, but it could be maybe contributing to his heart rate. His measurements also indicate that he may be at risk of developing a further heart problem. He is currently overweight. His BMI is 29.3, which means he is considered to be overweight. He already has heart problems, and from obesity comes a consequence of increased heart rate. Because he is carrying that extra weight around, he is becoming more puffed out, and this could be a reason why his heart rate is higher.
Heart failure is an ongoing condition in which the heart muscles is weakened and therefore cannot pump adequate supplies of blood throughout the body. Heart failure can be caused by any conditions which reduces the efficiency of the heart muscles through damage or overloading. Subsequently, Patrick's previous history of myocardial infarction is a factor that can be linked to this progressive heart failure. The result of this infarction caused a region of necrosis to occur and consequently causing damage to the heart muscles. Death of these cardiac muscle cells, the expansion and remodeling of surviving cells, accelerates scar formation to compensate previous loss. However, the deposited collagen to support and maintain structure, the contractility is decreased and is less functional. Consequently, the ventricles become bigger, filled with blood, and unable to sufficiently eject blood, causing congestion and the end result of heart failure. Failure of the left side of the heart is caused by this congestion, with the left ventricle unable to properly pump out blood to the body. Furthermore, failure of the left side of the heart causes blood to congest into the lungs, causing respiratory systems as well as fatigue due to insufficient supply of oxygenated blood. Patrick's diagnosis of COPD and progressive left-sided heart failure are both two conditions that continue to exacerbate one another. Responsible for receiving oxygen-rich blood from the lungs, the left side of the heart is needed to provide adequate blood flow to the systemic circulation. However, blood not properly oxygenated due to COPD places extra stress on the heart and further worsens the symptoms of left-sided heart failure. Conversely, the excessive fluid in the lungs due to left-sided heart failure can make breathing difficult for Patrick and his condition of COPD.
COPD leads to pulmonary edema and pulmonary hypertension, and alongside left-sided heart failure and previous MIs, is a common cause of right-sided heart failure. It results in increased preload and increased afterload, yet decreased contractility. Alveolar hypoxia and pulmonary vasoconstriction can lead to remodeling of the lungs at the pulmonary vascular bed, with a diversion of blood flow from areas of severe damage, such as regional alveolar hypoxia, to better ventilated areas of the lung, and hypertrophy alongside other physical changes the lungs and heart try to compensate. When extensive parts of the lungs are involved, it results in pulmonary hypertension and increased pulmonary resistance, as previously mentioned. This causes an increase in workload for especially the right ventricle, which can result in dilation and hypertrophy of the right ventricle and eventually leads to right-sided heart failure. Patrick has previously had a myocardial infarction. He is over the healthy weight range and has an extensive history of smoking. With his current fasting blood results, we can directly connect this with his medical history. Hypertension needs to be avoided as it increases the risk factors of COPD and heart failure. Risk factors for hypertension include smoking, obesity, alcohol, family history, being a male, a high intake of sodium, a low intake of potassium, chronic inflammation, and hyperglycemia. Most of these factors we'll be discussing further. Patrick's below the recommended high-density lipoprotein, which helps protect from heart disease by removing low-density lipoprotein from the peripheral arteries and returning it back to the liver, where it can be further broken down and removed from the body. His higher than recommended low-density lipoprotein, which is responsible for clogging arteries and causing atherosclerosis, is a possible cause for his previous MI. As Patrick's fasting glucose is above the recommended 6.1 millimoles per litre, this hyperglycemia is a sign of diabetes mellitus or pre-diabetes, another risk factor for many previous health incidences. Glucose is vital for the body's functioning and can be stored as glycogen within the liver. Non-selective small-sized particles are filtered into the nephron tubules from the afferent arteriole at the glomerular capsule. Water, glucose, sodium, potassium, calcium, and urea are all small non-selective particles that are filtered and have been examined within his fasting blood tests. Another blood test result that would help explain and fits with Patrick's current condition and symptoms is his hemoglobin levels. His reduced capacity to deliver oxygen around the body and return carbon dioxide to the lungs is another contributing factor to his increased respiratory rate. This reduction in hemoglobin may be indicative of anemia, which could be due to insufficient dietary requirements, kidney disease, and a multitude of other reasons, which will worsen Patrick's COPD symptoms. Potassium is vital for relaying nerve impulses, maintaining proper muscle functions, and most importantly, regulating heartbeats and rhythms. Patrick's hyperkalemia could be due to certain medications, particularly blood pressure medications such as ACE inhibitors and beta blockers. His current potassium levels may be a contributing factor to his heart rate. Minimal sodium helps your body balance water levels and helps with nerve impulses and muscle contractions similar to potassium. Irregularities in sodium levels may indicate dehydration disorders of the adrenal glands, excessive intake of salt, or problems with the liver or kidney, or medications that are used to balance our blood pressure, such as diuretics. Patrick's sodium levels are above the recommended and could be having a significant impact on his blood pressure due to an increase in water reabsorption in the nephrons, therefore increasing the pressure on his heart and lungs, worsening both COPD and heart failure.
Conducting an additional blood test, results would indicate an abnormality found in relation to Patrick's blood pH. Blood pH is maintained within a tight range to avoid cellular death and is often achieved through buffer mechanisms. Under normal circumstances, Patrick would exhibit a pH regulated within a range of 7.35 to 7.45. However, these new test results would display an abnormal result of a lower blood pH. This is due to Patrick's condition of COPD, as there is an alteration in pulmonary ventilation. This alteration of gas exchange, the excessive retention of CO2, rapidly accumulates in the lung as it is unable to be adequately expelled. Consequently, CO2 dissociates with the release of hydrogen ions in the body and results in a higher concentration of hydrogen. As there is a shift, there is an imbalance, as there is excessive hydrogen causing the blood to become more acidic and henceforth lower blood pH.